Hello, this is my presentation about resilience in nursing, combating nurse burnout. My name is Theresa Seeger and I am a DNP candidate. So the role of the nurse has changed in many ways since the initial days of Florence Nightingale. Nurses have taken on a broader scope of responsibilities and practices that require more education, more critical thinking, and more compassion. This new function of the bedside nurse, both at the RN and APRN, Advanced Practice Registered Nurse, level, has been shown to lead to chronic stress and fatigue due to the emotional demands, as well as the emphasis that is placed on their productivity, with their own health often falling to the wayside. While this concept can be difficult to diagnose and classify, the term burnout has been used to describe this persistent psychological stress that is associated with physical and mental health issues and a decrease in productivity in the job. Emergency department nurses have been shown to have a significant level of burnout, with up to 60% of nurses showing moderate levels due to the high stress and traumatic situations that they are exposed to every shift. While many attempts have been made to combat this phenomenon and bring nurses back to their peak health, only some methods have been shown to be successful. The purpose of this scholarly project is to reduce burnout in emergency room nurses and APRNs by gathering initial data and then implementing a mindfulness regimen practice. By identifying a baseline level of burnout in emergency room nurses using a validated tool, the change in stress level can be measured accurately after carrying out a program that strives to decrease chronic stress in this population. The literature was analyzed to identify the most successful methods of preventing burnout, including resilience training, meditation, mental exercises, and work-life balance methods. This project ultimately hopes to implement a sustainable method to decrease and combat burnout in emergency room nurses and provide a foundation for future intervention strategies in high-stress nursing environments. For methods, so a quantitative pre-post study design was utilized for this project. The participants were engaged in the project, however, all potential personal identifiers were removed to maintain anonymity. The researcher recorded only pertinent demographic information and nothing that could identify the participant. After International Review Board IRB approval was obtained from Maryville, administrative approval was obtained from the facility in which the project was conducted. The primary researcher sent out an email to the staff nurses and advanced practice nurses of the ED and announced the project with subsequent information. Flyers were also distributed around the ED. The primary researcher began twice daily announcements at huddles prior to each shift, sharing information and answering any questions about the project. At each huddle, a sign-up sheet was available for participants to join the project. A paper packet was provided to those to join the project at the huddle. This packet included the implied consent form, demographic information, and a preliminary Maslach Burnout Inventory, or MBI, assessment. For those that signed up for the project through email, they also picked up the same paper packet from the command center. The preliminary assessment and demographic information for those participating was collected by placing a locked Dropbox in the comm center of the ED. Only the primary researcher had a key to this Dropbox, and there was no identifying information on the packets. All the packets were collected by the end of week 2 for this preliminary data gathering. So this is an example of what one specific question on the MBI survey looked like. It consisted of 22 questions total, and the participant would rate how often they felt a particular emotion within a particular scenario, either from never felt it to every day. Examples of some of the questions included things like, I feel emotionally drained from my job, never to every day. I have become more callous to patients since starting this job, and I feel exhilarated when working with my patients. And then you would rate it from I never feel this way or I feel this every day. So by The last day of week 2, an email was sent to those who signed up with an even further detailed description of the task that they needed to complete, as well as the resources that were available for this intervention. The participants were required to participate in at least 2 mindfulness sessions per week for 6 weeks. These sessions were between 10 and 30 minutes in length, and the participant was able to listen to the sessions of their choosing. They were able to choose from about 15 to 20 different sessions. While it was encouraged to listen to these sessions on a day of work, either before, during, or after a shift, this was not a requirement, as each person may benefit from a mindfulness-based stress reduction, or MBSR, in different ways and at different times. For weeks 3 through 8, the researcher was available in person or by email for any questions that they may have, but otherwise stayed hands-off. At the end of week 9, a blank secondary assessment was available for pickup in the ED Comm Center for the participants and then collected in the same locked drop box. An additional section was added asking about the participants' thoughts about the projects, their views of mindfulness, if it was beneficial or not, and if they will continue to incorporate mindfulness into their lives. The pre and post surveys were connected to each other by a PIN number written in the right-hand corner of each survey, but this was known only to the participants. For the results, in this study, there were 3 separate scores being measured to evaluate burnout: emotional exhaustion, or EE, depersonalization, DP, and personal accomplishment, PA. These scores could not be added together, and they had to be evaluated independently. They are 3 separate variables that were tested. A paired t-test was used on each of the data sets to compare the pre-intervention scores for each of these variables to the post-intervention scores of these 3 variables. The raw data that was collected from the participants met all of the needed assumptions for a paired t-test in order to compare the pre-intervention and post-intervention scores for each category. Each of the participants had 2 dependent variables, pre- and post-intervention data. They were measured with a ratio measurement, the 7-point Likert scale that we were shown earlier, and they were approximately normally distributed. So the significance value used for this data was p equals 0.05, with the null hypothesis assuming no change in the pre- and post-intervention data, which is pretty standard for the paired t-test. The paired t-test was run on this data, revealed some important information that you can see down in Table 1, including the difference of the mean, standardization, standard error, and degrees of freedom. The mean differences for each category indicated that, on average, the emotional exhaustion scores decreased 0.27 points, depersonalization scores decreased 0.09 points after the implementation of the mindfulness intervention. And you can see that the PA score increased by 0.04 points. The values of the T statistics were then compared with the calculated lower critical value from the lower tailed test on EE and DP and the upper critical value for PA to determine significance, because we wanted the emotional exhaustion and depersonalization scores to ultimately decrease, and we wanted the feeling of personal accomplishments to ultimately increase. So this paired t-test was used to compare pre- and post-intervention scores from all 3 categories after a mindfulness-based intervention was put in place. There was a difference in the emotional exhaustion levels, which was determined to be statistically significant. While there was a decrease in the levels of depersonalization and an increase in the levels of personal accomplishment, neither of these were determined to be statistically significant when compared to the accepted significance value of p equals 0.05. The role of the professional nurse has significantly changed since its origination as a career, including the addition of more technology, higher acuity and complexity of diseases and their treatments, and the duties included within the scope of practice for nursing. With these changes, an increase in job-related stress and fatigue, termed burnout, has become more apparent. The level of burnout, often measured by 3 variables, as discussed earlier, emotional exhaustion, depersonalization, and personal accomplishment, is able to be mitigated with a combination of both systemic changes and individual coping strategies, such as mindfulness-based stress reduction programs. This project analyzed the 3 variables of burnout after implementing a 6-week MBSR program and found an improvement in all 3 variables with a statistically significant decrease in the participants' emotional exhaustion levels. These results indicate that a mindfulness-based stress reduction program in critical care and emergency settings can be beneficial in lowering RN's and APRN's level of emotional exhaustion, which is a major component of burnout. The data analysis also indicated a positive trend in the depersonalization and personal accomplishment levels, which are the other 2 factors of burnout, though these were not considered statistically significant. Mindfulness and stress reduction programs can be beneficial in addressing burnout and also preventing it by equipping participants with methods to deal with stressors both during and outside of work. A pilot study conducted in 2018 indicated that interventions can be incorporated into daily life, not just in the work setting. These interventions had a better chance of reducing stress and bolstering positive mental health in nurses. In a number of other studies similar to this project, the emotional exhaustion variable more often had a significant change than the other 2 variables. In those that had all 3 variables improving statistically significantly, the study usually took place over at least 3 months, if not longer. Many relevant studies that looked at mindfulness interventions and the effects on burnout in nurses had at least 50 participants, with others having almost 500 participants. There was a significant gap in the literature on studies that looked at burnout specifically in emergency nurses, as well as studies that included APRNs. So this study really strived to fill that gap by including these unanalyzed populations. There was a much lower participation rate for this study than originally was anticipated. This could have been due to the increased environmental stressors and workload of this particular ED from the COVID-19 surge in the area, leading to increased patient census and high levels of acuity. The study was also only advertised for 1 week, potentially missing some nurses or APRNs who have taken paid leave or had not been present during that week. Additionally, the study used volunteers and not randomly selected participants, so it was not able to capture the effects of a MBSR program on participants that were not already open to its effects and willing to try it. There were likely some bias within the data collection, including response bias from the participants themselves. As instructed in the MBI manual, this study strived to omit the word burnout from the survey where able, but preconceived notions and sensitization to burnout may have swayed the responses. Additionally, self-reported answers on a topic with ambiguous definitions such as exhaustion and depersonalization can be difficult to measure. Though confidentiality was ensured to these participants, admitting to burnout can often feel like a failure, particularly in a field like nursing that is centered on values such as altruism and caring. This feeling may have impacted the data gathered if participants were not completely honest. When considering generalizability, it must be considered if these results can be generalized to a population as well as generalized to a theory. Because the sample size was smaller than anticipated and much smaller than other similar studies, the generalizability of the results to be applied to other similar population of emergency department RNs and APRNs is weakened. The significant results of an improvement in emotional exhaustion is similar to other studies of like design, as we mentioned above. This supports the idea that a significant change in emotional exhaustion after an MBSR program could be generalized to the greater population of emergency department RNs and APRNs. Again, compared to other studies of similar investigation, this study analyzed the change of burnout nurses over a shorter period of time, only 1 month. While the results of this study were promising, much of the literature on burnout in healthcare points to the multifactorial contributors that must be modified in order to contribute a sustainable defense against burnout. So for future research, because of the lack of strength and generalization across the board for this specific project, as discussed previously, further research is encouraged on the topic. This is especially true concerning the specific interventions that may combat burnout in RNs and APRNs working in the emergency medicine setting. Interventional research can be difficult and expensive to conduct compared to like chart review or just data gathering. Having the system, including management, on board with the intervention makes the process run smoother and become more sustainable. For future research, I would suggest prolonging the mindfulness program to longer than 6 weeks to identify if a more sustained intervention creates significant changes in all variables instead of only emotional exhaustion. Further analyzation should also be focused, again, on both individual factors, such as resilience and mental health, as well as systemic factors, such as workload, adequate staffing numbers, and promoted work-life balance. While this study focused on the individual characteristics and coping as contributing factors, literature supports that multifactorial interventions and bundles are often more effective against burnout. Future studies should also attempt to fill the gap of how mindfulness-based interventions contribute to other burnout indicators such as days of work missed, frequency of mistakes such as med errors, and rate of employee turnover. This information would further reinforce the benefits of a MBSR program in numerous areas of work. From the beginning of this project, a main point of interest has been the negative impact that burnout can have on the quality and safety of healthcare. There's little contention that higher levels of burnout can have significant negative effects on patients, staff, coworkers, and family members. In fact, this is one of the primary themes that we discovered in this project's primary literature review. Briefly, higher levels of burnout in nurses and all providers, really, has been shown to be detrimental not only to providers on an individual level, which includes increased health issues, decreased quality of personal relationships, and decreased job satisfactions, but also detrimental to organizations on a systemic level. This includes high turnover, decreased job commitment, more on-the-job mistakes, and increased employee absenteeism. Emotional exhaustion has been shown to have the strongest relationship with quality of healthcare provided. Since this project supported the significant decrease in emotional exhaustion levels after a 6-week MBSR program, it is likely that a continuation of this practice would in turn improve the quality of healthcare provided in a similar environment, though further research, of course, would need to be conducted. Improving quality and safety of health care provided is in the best interest not only for the providers themselves, but also the organization that they work in. Employee dissatisfaction can end up costing the organization additional money through higher employee turnover, increased missed work, or a lower quality of work, as well as the cost of retraining new employees. Adverse events such as medication errors can place the organization at a higher liability risk, leading to longer patient stays or a higher mortality. Patient satisfaction, which is negatively impacted by provider burnout, also impacts the organization's reimbursement levels. Though they may not realize it, patients themselves and the general public are impacted heavily by the level of burnout in healthcare providers. As the ones on the receiving end of this care, they stand to be the most affected by the medication errors, poor attitudes, and generally overly stressed providers that are caused by burnout. While interventions on an individual level are shown to improve emotional exhaustion, as well as personal accomplishments and depersonalization, implementing policies on the organizational level can move these improvements to a more sustainable function. Particularly in the age of the COVID-19 pandemic, reducing burnout in all levels of healthcare providers has been declared a health goal across the world to ensure patient and staff safety. Enacting strong policy that supports all providers in coping with burnout and stress can help solidify the opportunities a MBSR program may offer and create a more sustainable impact on the emotional well-being of all employees. An example of a potentially enacted policy could be that each department must provide a quiet space for its providers to step away from the unit or work environment in order to practice a short mindfulness session, guided or not, such as those that we presented in this project. Another example could be the organization of a unit-based or organizational-wide committee that focuses on the multidimensional factors that contribute to and combat against burnout, including mindfulness opportunities. This would allow for individual resilience strategies to be intertwined with these systemic changes, which literature has shown is the most effective way to prevent and decrease levels of burnout in healthcare providers. The idea is not that healthcare policy forces mindfulness-based coping strategies on the providers, but rather to give them the education and opportunity of such a program. Especially with the added strain of the global health pandemic, burnout really has become a more well-discussed and thus more studied topic within healthcare. Organizations as well as individual providers are beginning to understand the benefit behind prioritizing the mental health of nurses at all levels of practice. By implementing these sustainable changes, including healthcare policies that provided nurses the opportunity to cope with and prevent burnout, healthcare practice can be positively impacted in all areas, including quality, safety, financial, and on a personal level. Creating healthier, more satisfied nurses can increase the retention of staff and productivity within the unit, as well as improve the resilience for the staff during times of stress. Providing trauma-informed mindfulness opportunities to address these concerns would provide a direct benefit to nurses as employees, but also as people. This is my contact information as well as my academic chair. If you have any questions, please feel free to reach out to me. I am very passionate about this project and would love to speak with anybody and give you more information. I really want to thank everybody who participated in this project, as well as all my peers throughout this whole program who really helped review all of the papers that I submitted and all of the things we had to do throughout this project. These are my citations. And again, thank you so much for listening.